Good afternoon or good evening, everyone, and welcome again. My name's Troy, and I'm the Chief Operating Officer of Nurses Specialized in Wound Ostomy and Continence Canada. So, thank you for joining with us today for another edition of our continuing education webinar series. Today, we're going to be talking about pain. What can you do? And today's session is a part of our long-standing webinar series now in partnership with Perfuse MedTech and the Canadian Home Care Association. This series has been bringing together internationally recognized wound care physicians, such as those who I'm about to introduce, to discuss practical, evidence-informed strategies for lower limb wound care across many different care settings. Before we begin, if you want to click on that chat button in your Zoom toolbar, I can see a lot of people are doing that already. Maybe just type in the chat where you're tuning in from and let us know what your job title or what your role is, maybe what your relationship to wound care has been over the past few years. We're going to be having a Q&A session at the end of today's session. So if you have any questions, please click on that Q&A button in your Zoom toolbar rather than the chat. That way we can keep them super organized and get to as many as possible. We're going to be sending out a certificate of attendance after this webinar. Just give us about 2 business days at the most, and we'll get those into your inbox. We'll also send that recording link along with that certificate so you can watch this after the fact too. And we do post it to our NSWOCC.ca website as well. So I have the ultimate pleasure of introducing our 2 guest speakers. Today we have back with us Dr. Robyn Evans, who's a family physician with enhanced training in wound care and serves as the director of director of the Wound Healing Clinic at Women's College Hospital in Toronto. She's actively involved in the clinical management of patients with complex wounds and has over 15 years of experience in wound care education and research as well. Dr. Evans is a board member of Wounds Canada, co-director of the Wound Champion program, and a lecturer at the University of Toronto, and continues to practice full-time as a community family physician. And we're, of course, also honored to have with us today Dr. Gary Sibbald, who is an internationally recognized leader in wound care with more than 35 years of experience in clinical practice, research, and education. Dr. Sibbald is a dermatologist and internist, co-founder of the International Interprofessional Wound Care course at the University of Toronto, and founder of Woundpedia, a not-for-profit global wound education initiative. He is the project lead for Project ECHO Ontario Skin and Wound and the Indigenous ECHO Canada Skin and Wound as well, and has authored over 270 peer-reviewed publications. So with that, actually, just before I pass over the microphone and the video here to everybody, I'll ask Andrew behind the scenes if you want to share the screen there. And we're going to be doing some polls today. So if you have an iPhone or an iPad, you might have to swipe over to reply to the polls. Otherwise, it should pop up right in front of you when we do launch them. So please do participate, and we look forward to the discussion today. Thanks, Dr. Evans and Dr. Sibbald. I'll pass it over to you.
Okay, thank you, Troy, for the introduction, and welcome everybody. It seems like across the country and even further. I saw tons of countries and provinces and Nova Scotia and Australia coming up. Quite impressive. Thank you to Gecko for sponsoring these ongoing educational sessions. And today we're going to talk about pain and with more of a slant toward what you can do about it. I feel that most of us focus on wound healing, which isn't a bad thing, but I think we sometimes forget a little bit about what we can do about pain. Next slide, please. So just read through these conflicts of interest. Um, I don't think there's anything that other than we both receive an honorarium from Gecko on this. So next slide. All right, it's always interesting for us to know where everybody comes from, and if you could please just enter into the poll where your highest expertise is from, so we helps us to design new programs and work towards making the best for you guys. So if we can quickly do this.
Perfect. And we got lots of responses, maybe just a couple more seconds. Lovely. I'll share the results on screen so you can see it there, but just to say it out, we're looking like the highest one is our RNs with just over 40%.
Okay.
RPN, LPNs next, quite a number of NSWOCs too, and some SWANs, nurse practitioners, and so on.
Great. Thanks very much, everyone. And in addition to that, and next slide, Andrew, we want to know how many years you've been in practice in doing specifically wound care.
think it's going to be across the continuum, Robyn.
Yeah, it's always interesting. I think people in wounds are always wanting to learn more. So, I mean, even if I've been practicing 15 years, I still want to know more. It's always, I learn something every time. All right. Wow, there's
I'll
some long ones here.
just share the result for you there. As I
Wow.
said, fairly balanced, but you can see the results there.
Yeah, that is. All right. Thank you. All right, so on to the next. We need to talk about what the objectives are for today's. Oh, one more here, sorry. How would you rate your ability to evaluate pain? And this was something I was quite interested in because I was looking at a study that looked at 500 nurses in Italy. So I was wondering what everybody here feels about their confidence in managing pain.
And while we're doing that, I just saw in the chat someone asking what SWAN means. SWAN is a skin wellness associate nurse. That's our RNs and LPNs across Canada who are specialized in wound ostomy and continence care. And you should be able to see the results now in front of you.
Okay. Moderately, sorry, it's flashed. So moderately confident is 68%, very confident is 28%. So that's impressive. So more than what the nurses in Italy felt. They felt 85% felt they were not adequately knowledgeable about conducting an effective pain assessment. Okay, next slide. All right, so the objectives. We want to review the general pain concepts and dissect the potential causes of pain and patient impact, assess the mechanisms and management of lower leg pain, uh, considering medication and other novel options, and then the integrated muscle pump activator known as Gecko and how that can be used and what its effect is on pain in venous leg ulcer management. Next slide. Okay, so we got to remember that pain is what the patient says it is. I mean, despite what the wound looks like, anywhere from a little abrasion, who someone can say is very painful, to these horrific looking wounds next to it, we still have to remember everybody is different and we have to be cognizant that the pain is what the patient says it is. Next slide. And Dr. Sibbald.
Mm-hmm. Here we are looking at somebody having an injury, so nociceptive pain, and often it's described as gnawing, aching, tender, or throbbing. But if you want to put it another way, it's like a toothache. And it's an inflammatory response to an identified stimulus or trigger for injury. But sometimes that trigger keeps on going at a stage beyond which there's a persistent injury to peripheral nerves. And it's like an inflammatory process that doesn't turn itself off. And this will result in spontaneous neuropathic pain. Next slide. And the neuropathic pain is often described as burning, stinging, shooting, or stabbing. And if uncorrected, you get a wind-up phenomena, and these individuals can have chronic pain. And the longer you leave it, the harder it is to control. Next one. What pain scale do you use? The visual analog, verbal rating, numeric rating scale? Ask directed questions when the patient complained of pain are not part of my scope of practice.
Alrighty, and we're just over about 50% participated, so maybe we'll share it now. Should be able to see results on your screen.
Yeah, and 73% the numeric rating scale, which is what I like. 0 is no pain. 10's equivalent to slamming your thumb on the car door, and 5 a bee sting. And most people can live with a 3 to a 4. Next one. And here you see the FACE scale, which is often used if individuals have trouble with comprehension, the very young, the very old, or people with mental disabilities. The visual analog scale is marking an X, and it's much better if you have that scale, that you show them the previous one to see if it goes up or down. The simplest is the verbal rating scale of no, mild, moderate, or severe, and numeric rating scale. And when we ask this question, how many anchors are there on the numeric rating scale? It's not 10, it's 11 because there's a 0. Next one. And it's an unpleasant sensory and emotional experience associated or resembling that associated with actual or potential tissue damage. Robyn, what do you think of that definition?
Well, it's been around since 2020. It's stood the test of time, and most people refer to it. I think it's more than just a one-dimensional evaluation of pain. So it speaks to the fact that it's an emotional experience and it's actual or potential tissue damage. So it's a little deeper than just what is pain. And I think the literature supports most of this in that reading through all the stuff I've read on pain, it really speaks to the fact that pain seems to be underassessed and probably undertreated, and that most people with venous leg ulcers, up to 80%, will describe at least mild to moderate pain that can be both nociceptive, neuropathic, or a combination of both of those things. And unless people have sort of a neuropathy or spinal cord problem, diabetes, pain tends to be a significant factor with leg issues. Next slide. So, which of the following is false? Uh, Neuropathic pain, I can't quite read it here, is aching and gnawing in character. Nociplastic is a chronic pain not related to tissue damage. And nociceptive pain is what you feel after an injury that causes tissue damage. Which one of those is false?
And just remember, it's the one that's wrong.
Ready, and we're almost at 50%. Let's go there. You should be able to see the results on your screen now.
Okay. So in the next coming slides, this will become very clear to you, but the correct answer, which one is false, is the first one. So whoever picked number one, 43% of people were correct. Next slide. All right, so there's three types of pain, and I think this diagram is very, it explains this quite well. Nociceptive pain, similar to hammering your hand, and I think most of you know what that feels like. It's tissue damage, direct tissue damage, and it's called nociceptive pain. It sends signals to the brain, and you feel that as acute pain. Neuropathic pain involves something that interacts with the spinal cord or nerves or the somatosensory system in some way, which can be trauma, disease, chemicals, many causes that neuropathic pain. I think nociceptive pain is the one that most people haven't heard about necessarily. Nociceptive pain was coined as a result of not being able to put people into this category of either neuropathic or nociceptive, and it's more attributed to an altered nociception without evidence of any actual tissue damage. And examples of this would be something like the regional pain syndrome or something like fibromyalgia. And this diagram is just showing that the pain response goes to the sensory areas of the brain, but there's been no actual tissue damage. Next slide. So it's important at the bedside to figure out what we're dealing with, and the history is of the utmost importance. And we want to know how to distinguish neuropathic from nociceptive pain because it makes a difference in terms of how you treat it. So neuropathic pain is burning, stinging, shooting, or stabbing, and often felt as pins and needles. I think anybody who's had shingles will know what feels like, or sciatica, or carpal tunnel. These are the symptoms that you get with those kinds of disorders. Whereas nociceptive pain, as Dr. Sibbald said, is more like a toothache. So it's more of a gnawing, aching, tender, or throbbing feeling, and similar to any kind of acute injury, like, closing your finger in the dishwasher or something like that. You know what that feels like. Next slide. So it's important at every visit to evaluate pain because it changes, and you need to evaluate whether the things you did last time have any effect on the patient's pain over time since your last visit. But pain can be divided into three different types, or you've got the background pain that's related to what is the cause of the ulcer. Is it ischemic, inflammatory? Is there an infective component, neuropathy? And is that pain continuous or intermittent? Incident pain is what happens that varies the pain with activities of daily living, such as walking. And I think most of us think about pain with walking. We worry about things like spinal stenosis and claudication. I think for all of us in listening to this webinar, claudication or arterial insufficiency is something we're always trying to tease out. So that is pain with walking a certain distance, pain in your leg that can be felt anywhere from the buttock to the foot, and that pain is reproducible for walking the same distance. Procedural pain, I think, is where we all need to sit up and take notice, because this is what we do when we cleanse, dress, debride, or put compression on patients. We don't think about it necessarily all the time, but all of these things can contribute to patients' pain. Next slide. And pain is more, it's modulated by many different things. So it's, as the definition said, it's a sensory component to this, and it's quite personal. You can have, certain people will experience pain differently based on genetics, past experience, whether they're super stressed, fatigue, sleep disorders, emotional issues play into this in terms of mood disorders, and same as cultural or social issues. There can be stigma within certain cultural groups to complain about pain, so people just don't do it. Age is another one. Some people, geriatric patients, are very stoic and they don't want to complain. So no two individuals will complain of the same pain. Pain is what the patient says it is. This picture on the right is a gentleman who has diabetes, and the guy never complains. And he actually didn't complain this time either when you look at that foot. I mean, obviously, I was very concerned about the foot, and I was sending him to Emerge to be admitted because he's had a renal transplant. But he didn't really complain about the pain. When I walked him out of the clinic, he could hardly walk due to pain. So, I mean, you really need to look at your patients and realize, understand how much pain they're really having. Next slide. Dr.
Okay,
Sibbald.
this is the wound bed prep paradigm, and I think you always have to treat the cause, and certainly for high-risk foot, and it's important because a foot ulcer is often the first step, and about 80% of lower limb amputations are in people with diabetes and start with a foot ulcer. You already heard about vascular infection. There is a mnemonic, NERDS, any three you treat topically. Stonies, deep and surrounding, you treat systemically. But pain is a symptom rather than a sign, and it can replace one of the signs in either if it's in the region of the wound and there's no other cause. Bandages can cause pain. And there's lots of patients that don't tolerate support stockings and bandages. And this is an important piece that I'll come back to in a minute. Patient-centered concerns. Pain is more important to patients than it is to healthcare providers. And we need to look at the ability to heal, and it's only healable wounds that should have moisture balance. Non-healable and maintenance wounds are really looking at bacterial reduction and moisture reduction. And we have to be careful about the amount of pain from debridement. Can certainly be very painful for sharp surgical debridement, and mechanical debridement can be extremely painful, but other forms of debridement may be painful as well. And you have to realize that with moisture management, you want moisture balance if it's healable, but if it's maintenance or non-healable, that's going to favor the bacteria, not the host, and you really want moisture reduction. The healing rate isn't 30% smaller by week 4. It's unlikely to heal by week 12, and this is where you might consider in the edge effect adjunctive therapies. The gecko is one, skin graft, electrical stimulation, hyperbaric oxygen and the vac would come in here. And each time we see a patient, you have to think, where are the parts of the healthcare system that aren't doing well for this patient, and how could we change this? Next one. Here is 526 patients that came into our office with leg ulcers, and although most of studies, 70 to 80% are venous, it was much less. It was 54% in our population. And we had venal lymphedema, peripheral vascular disease, trauma, cancers, and then you see some of the vasculitis post-surgical, pyoderma gangrenosum. So you have to realize if a wound isn't healing, you may have to look for some of these other etiologies. Next one. Robyn, this is kind of a duo slide so that I really saying if pain might limit compression, so you might use 2B grip or edema wear because it's lower compression. We know that non-elastic doesn't give you high pressure at rest, and it may be less painful initially than elastic. Often low compression is less painful than moderate or high. Zinc oxide paste is often very gentle and may not lead to pain. And we have other ways of helping relieve pain. One is pentoxyphylline. You might otherwise know it as Trental. Or we will talk about the Gecko device, which can relieve pain. And Robyn, what's your take on this?
Well, I think I know we always have to remember that the gold standard of treatment of leg edema and venous insufficiency and lymphedema is compression. But I think we have to also entertain the concept, of our patients' dexterity, mobility, flexibility, and cost are a big factor in what we choose for reducing compression. And I think also, no matter how much compression you put on somebody, if they constantly have their legs down and no activation of the calf muscle pump, you're going to have a hard time getting rid of that edema with compression alone. So I think we do need to think outside that box and manage to incorporate other strategies into our toolbox as well. And always consider, edema is painful. I can tell you after, I said this in the last talk, but I broke my leg a while back and had surgery. And I can tell you the edema was more painful than the actual incision post-surgically. So I think we forget about edema as a cause of discomfort to patients. The distension is really uncomfortable. Next slide. But I always worry about sudden increase in pain. And I think, one of the things, as much as the history is important, the other thing you don't want to miss are things that are going to kill or significantly cause morbidity and mortality to your patient. So I think one of the things you always have to think about, a sudden increase in pain, is a blood clot in the leg or a deep vein thrombosis. And this would be the patient. I mean, obviously consider the risk factors for blood clots. But if someone presents with a unilateral, painful, swollen red leg, it's unkeeping with what you've previously seen with your patients and quite new, I think you really have to rule out a blood clot. And this is not terribly difficult to do in most settings. Referring for ultrasound is fairly easy to do. I mean, some people have to refer to emerge, but I think if you're seeing this, you're bound to do something about this acute onset. But that aside, I think the other thing you really have to worry about is bioburden, and pain is a validated indicator of infection. Biofilms, we talk about a lot. You can't see the biofilm, but we know it's a little nasty community of bacteria that sort of house themselves in a castle that's pretty hard to get to, but release toxins and proteases and push the inflammatory response, causing change in wound exudate. It's more inflamed looking. The granulation tissue is no longer healthy. You might notice an increase in odor and increase in pain. And using some of Dr. Sibbald's tools like the NERDs and Stonies will help you identify infection. Biofilm, not necessarily, but there's other indicators of that. We have a lot of dressings to address the problem with infection. And this is, again, I know that, you get orders a lot for applying dressings, but I think when you identify infection, it's up to you now to communicate back to the either physicians or whoever's ordering it or to other persons that are looking after the patients that another treatment might be required. So we know there's 5 antimicrobial agents. So there's the polyhexamethylene biguanide, which is known as PHMB, gentian violet, methylene blue, cadexamar iodine or any povidone, and as well as the silver products and honey. So there's a lot of choices for this, but it's really a clinical diagnosis that we are all required to do at the bedside. Next slide.
Okay, when we look at local wound care, there are 3 components: debridement, infection, inflammation, and moisture management. On the next slide, and if you want to take a picture of this, I'm fine. Cleansing solutions. If you're in bacterial balance, you only need sterile or potable, which is drinkable water, or saline. If you're not in bacterial balance, you have a choice of probably 3 main ones and 3 or 4 others. But acetic acid is white vinegar, 5%, usually diluted 1 in 5, which is 1%, or 1 in 10.5. Be careful, there is vinegar that's 10% for cleaning solutions and for floors, etc., and not as something that you would mix a salad dressing in. And there's apple cider vinegar and various fancy vinegars, but it's plain acetic acid. Hypochlorous acid does the same thing. It lowers the pH, but it's also got some antibacterial mechanisms as well. Pure Cleanse is the Canadian product. VASH is a second option, I believe, manufactured in the States. Chlorhexidine is a water base, and it's often used, the mouthwash can be used for patients that have got smelly areas under their arms, like with hidradenitis suppurativa and pain, and in the groin. And you can cut down bacteria by putting this in a spray bottle. It is a prescription, but 475 mils are under $30, and using it in a spray bottle for some wounds may be useful. Probably even better is PHMB, and it's a derivative of chlorhexidine. It's safe for the eyes and ears, whereas chlorhexidine is contraindicated. And in fact, PHMB is the most common preservative in eye and ear drops. And it comes with a surfactant, and that's called Prontosan, which is available on many of the wound care protocols. When we looked at therapeutic index, which looks at the safeness for host cells over what is the mean bactericidal concentration, hypochlorous acid was best for Pseudomonas, E. coli, and staph. PHMB was really Prontosan, etc., was really good to treat MRSA. But those 2 certainly have less tissue toxicity. Although povidone iodine 10% betadine has a greater tissue toxicity, it's got a broad spectrum. And in a lot of non-healable and maintenance wounds, it may be the antiseptic of choice. It's got several mechanisms. It treats gram-positive, negative, and anaerobic bacteria, yeast, true dermatophyte fungus, and viruses. So it's pretty good. And, but you don't want to use it on a healable wound and delay healing. When you're cleansing a wound, irrigation may be harmful, and you don't want to put it in too heavily. And if you can't see the bottom, then you could be collecting fluid somewhere deeper down below or beside the wound, and you really don't want that going along fascial planes or collecting internally. So I think irrigation, probably I prefer compress, or a cloth or gauze ribbon is put in the solution, wrung out lightly, put on the surface or in whatever sinus or area of undermining, and it's left for a minute or so and then taken out. And the net movement is fluid from the wound into the gauze or into the chlorhexidine or whatever substance that you're using, hypochlorous acid. A soak is when you leave the cloth or the gauze wet and you just take away the extra dripping. You put it on a wound, and the net movement is then from the cloth or gauze into the wound. And that would be to hydrate the wound if the wound surface is too dry. Next slide. Sometimes there's a lot of pain with cleansing and debridement, and topical anesthetics in the wound, we avoid benzocaine, which is an ester class of local anesthetic, and that has a high sensitization potential. MLAW is a eutectic mixture, and that's when two powders fall on a table and they liquefy, changes the melting point. And these are both xylocaine and prilocaine, each 2.5%. They're both amides, low sensitization, cover with saran, leave for 30 to 40 minutes or even 60 minutes. And this helps to give you a local anesthetic effect so that debridement will not be too painful. That can be supplemented with interlesional, sometimes xylocaine, sometimes with adrenaline, so that you don't get a lot of bleeding. You don't want to use that on a distal area. There's topical xylocaines, 2 to 5% cream gel ointment or spray. And those are alternative. And there are topical agents to use around the wound. And over the counter, patients, or you can buy Voltaren Emagel, which is 1%, or extra strength Emagel, which is 2%, and use this on painful areas. If you're worried, especially in somebody over 65, where the non-steroidal anti-inflammatory agents are more harmful. That's over-the-counter Pennsaid drops are Voltaren 2%. Can use it 4 or 5 times a day, and you can use up to, I wouldn't say 40, but 10 drops per application. Next slide. We did a randomized clinical evaluation, and this was before a multi-centered trial in which we took 12 patients. There is an ibuprofen foam dressing. It's relatively expensive. Got to use it for the right person at the right time, and where systemic agents are not used. We compared the foam alone to 12 patients with local best practice, and it contained the ibuprofen foam. And rated their baseline pain after the first dressing, mornings and evenings. No adverse events. One patient failed to return in over 7 days. The morning pain intensity score dropped significantly with the ibuprofen. So it was really quite interesting. Such a small group, and we were just really trying to see if we're measuring the right things. And on the next slide, and we got decreased pain, but decreased acute pain at dressing change, decreased peri-wound erythema, and it provided superior exudate management. And the wounds actually even started to get smaller after a week, whereas the wounds without the ibuprofen and the wounds started to expand. And that's part of the remodeling. Next slide. So you don't put gauze or something between the foam and the wound. And in the random controlled trial, it did give pain relief, and it did show, in addition to moist wound healing, would reduce wound pain during dressing wear time while maintaining a beneficial safety profile. And that was on many more patients. Robyn, although we don't use it often, it does have a use within selected patients.
Yeah, it does. I think it's something you need to remember to use. I think it's worth a try if it's not super exudative and there's no infection. And sometimes these inflammatory wounds are good ones to try for that. So there has been success. It is a fairly expensive dressing, but I think in the right patient, it's worthwhile.
Okay, let's go on to the next slide. And this is fragile skin. And this is where you should avoid acrylate or adhesives that really stick to the skin. And the silicone or the non-adherent dressings would be better. For healable wounds, foam for moisture balance if the cause has been corrected. Maintenance and non-healable wounds, you really want superabsorbents. You want the fluid to be absorbed and you want it to stay there. You don't want it going back. And topical antiseptics where antibacterial action is more important than tissue toxicity. And something like macerated toe webs where fungus might do that, and patients with neuropathy, and then bacteria get in, and through retrograde lymphatic spread, they cause the cellulitis in the lower legs. And if you see somebody in a merger with an acute cellulitis, no puncture wound, no evidence of where it came from, check the toe webs. Always check the fourth and fifth toe web first, because that's where there's the greatest occlusion, and often you get the greatest amount of maceration. Next one. And this is just to a non-healable or maintenance wound. Moisture balance and active debridement contraindicated. You might conservatively remove slough because two surfaces of different viscosity favors biofilms. Topical antiseptics will decrease local bacterial counts. And I did mention the hypochlorous and PHMB having the best therapeutic index. You can look that paper up. It's really downloadable. Was the CE paper in Advances last year in January. And decreased bacterial surface counts, decreased penetration into deeper tissue. And so, we have a role for topical PHMB gauze, but the PHMB stays in there, povidone iodine and polyethylene glycol base. Well, that is otherwise known to you as inidine. It releases the povidone iodine slowly so that you get less damage to the tissue. Next one. Okay. What's the most likely diagnosis here? Is it arterial, vasculitis, venous, livedoid vasculopathy? That's a big word. Cellulitis with ulceration.
Already nearly at about 50% here. Should be able to see the
Okay.
results on your screen now.
Yeah, so 37% said venous ulcer, and that is the correct answer. Arterial ulcers are often punched out and not serpiginous or irregular or serpentine-like border. Let's go to the next one. And you often get a heaviness, aching and cramping, especially at night. Locations usually in the gaiter area. Dusky ruby color, hemosiderin staining will lead to hyperpigmentation, and it's often combined with melanin. Irregular wound, well-defined borders, edema, dermatitis, and measuring pitting edema just above the malleolus area is where, and around the medial malleolus, where the superficial saphenous vein is most superficial, is where you get most of the edema most quickly. Robyn, this is yours.
Sure. So I want to remind everybody on what's happening with venous disease and how we get this venous hypertension. So I'm big on looking at what the pathophysiology is to understand where the pain is coming from. So just a reminder that valvular incompetence is a problem over time. The valves don't close and we get backflow of fluid. Instead of going up the hill, it's coming down the hill and fluid gets into the spaces. Obstruction or clot, important in terms of DVT. Causing damage to the deep vessels. And then the big one is failure of the calf muscle pump. If you can't pump that fluid back up the hill, again, it's very difficult to manage edema in the lower extremity. So what's happening is you're getting dilated capillaries and accumulation of blood in the skin and microcirculation. And this is causing an accumulation of white cells, iron, cytokines, inflammatory factors that are pushing this more into an inflammatory phase, making the bloods become stagnant and you're getting deoxygenated blood in the tissues. So this is causing more of a localized venous ischemia as well as regular edema that's causing it. And this is what you see clinically. So as much as you're seeing an inflammatory problem in the tissues, which more the microcirculation, macro effects are edema, dermatitis. Dermatitis is itchy. Dermatitis can be uncomfortable. The lipodermatosclerosis is that woody fibrosis can be painful. And then, of course, you get ulceration. So there's two aspects of pain that need to be treated here. It's the inflammatory part and what we're seeing on the skin and the surface. Next slide. So they hurt. Venous leg ulcers are painful, and I think most of you experience that in your visits with patients. It's the chemical irritation on the nociceptors, and it's this mechanical stress that caused from tissue breakdown and this edema, which I think is uncomfortable. And then you get some chronic effects. So chronic pain is a disease, really. Acute pain is a survival effect. Whereas chronic pain, you don't need that, but you have it and you can get this heightened pain response. So pain can occur during dressing changes, what we're putting on, how we take things off, what we use to debride the ulcers, how we cleanse the ulcers, what we decide on for compression. And Dr. Sibbald alluded to the elastic versus inelastic. And I think anybody who was on previous talks realized that inelastic compression doesn't really give you a lot of compression at rest. So if people have a lot of pain, this is someplace you want to start. Or is it due to ischemia, nerve and skin damage, inadequate oxygen supply around the wound? And even with our lipodermatosclerosis, this is something that's happening. You've got this scarred down fibrotic tissue. Oxygenation is not great, so we need to improve that. And then we have the issue with infection, which is causing an inflammatory reaction and irritating nerve endings and causing increased pain. So there's many reasons why venous leg ulcers hurt and many reasons what we can do to improve that. Next slide. Dr. Sibbald?
Okay, here we see the venous ulcer in the left upper picture and serpiginous edges. In the left lower, those are both arterial ulcers, and you see the distal gangrene that everybody recognizes. You also see some proximal areas where you can see tendon in the base, and you seldom see tendon in the base in a venous ulcer. They're much more superficial, and this would be a smoker with the tendon that is exposed in the front of the leg, and it may be a shopping cart or the washer door where an injury. And once you have an injury, you need more arterial supply to heal. And all of a sudden it breaks down, it's punched out, it goes down to tendon, and there's no signs of healing. And in fact, depending on the amount of arterial compromise or if the person's smoking, and every cigarette will decrease the circulation 30% for an hour. The one on the right side, okay, is a livedoid vasculopathy. You see these are small vessels that get clotted. And sometimes you'll see atrophy blanche, sometimes hyperpigmentation. You can see this kind of change in venous disease just around the malleolus, but it doesn't go up the gaiter area and it doesn't go down the foot to the base of the toes. And this tells you that there's something else going on. And this condition can be extremely painful. And they may have normal large arteries, and it's only the small arteries that are the target. And these patients need really good pain control. Next slide. Here's a case study. 75-year-old, an ulcer on the lower leg, 6 months with significant swelling and pain. Pain was 6 out of 10 with visits to the clinic, otherwise 4 out of 10, intermittent burning and stabbing. So you've kind of got a neuropathic and a nociceptive component, which is common, and often both components are not treated. Pulses are excellent. There's a biphasic Doppler waveform, and that means that the EBPI is greater or equal 0.9. He's taking a Tylenol, which is acetaminophen, a gram twice a day for pain that helps, cleansing with saline, applying a silicone foam dressing with Coban 2 Light. So this is more of a non-elastic than an elastic system. And he tends to remove this after 12 hours. The nurses have tried edema wear, and he feels like it's cutting his skin. All right, what would you do? Would you try an unspaced boot for compression? Use 1 to 2 layers of Tubi grip, legs up on a two-seater couch or recliner chair while seated, and do not cross the legs. Velcro fastener system with both leg and foot adjustable components. And those systems are available on Ontario Home Care. I'm not sure about other areas across the country. And refer the patient to a wound care specialist or interprofessional team. What would you do with this patient? And I can tell you here, there may be more than one correct answer.
And Andrew, once you lodge that vote, maybe you could go back to the picture. And while they're doing that, Dr. Sibbald, before this, you mentioned vasculopathy and management. What would be your management choice for vasculopathy?
Well, it's interesting. I often use Trental pentoxyphylline, and it is a xanthine, so like coffee, and it increases red blood cell contractility. It's anti-inflammatory and it's fibrinolytic. The other thing is we often use low doses of rivaroxaban, 2.5 milligrams twice a day, and that often helps, but you may need the acetaminophen. And what that patient was missing is Lyrica or Neurontin in the daytime, and maybe nortriptyline 10 to 30 milligrams at night. It really is very painful, and it's very much, first of all, not recognized, and second of all, often undertreated.
Right.
All right, let's go on. Let's see the answers. I lost them. Oh, they're here.
Oh, you should be able to see them now.
Yeah, I can. Yeah, I can. Sorry, I was looking at the screen. Refer patient to wound care specialist, 46%. Perfectly fine. The next highest is use an unspaced boot. And the unspaced boot is often very soothing, and it does not have very much compression at rest. It was invented by a German dermatologist in 1895. So you got to say 150 years later, that has withstood, or 120, 130 years later, withstood the hands of time. And before we had topical steroids, it's very anti-inflammatory, and it's much better than using often coal tar type of bandages were used in the past, and that's much more irritating. 14% Velcro fastener system. If you have it available, it's great because the patient can, both on the foot piece and on the leg piece, do adjustments, and that gives patients a much better level of control. 2 layers of Tubi grip, 1 or 2, might not give you as much compression, but if that's what the patient tolerates, then that's fine. Legs up on a two-seater couch with a recliner. If nothing else works, or until you get pain control, that might be the best method of doing things. Robyn, what did I leave out of that?
I don't know. What did you leave out of that?
No, I'm asking you what else to recommend.
Oh, what else? Um,
If you can't find anything, I'm happy.
no, I think you covered. I think some people in the audience might be wondering that that leg looks pretty inflamed and there's a lot of moisture there. I'm probably worried a little bit more about the dressings as well. And I think there could be an improvement in the dressings, maybe the frequency, the compression. I think this is a perfect case that most people could manage this leg and get this patient fairly much improved in terms of the pain just by altering the dressing and the compression, and a bit more patient education, I think would really help. So I
I
think there's
have
a
a
lot you could
feeling
do.
Now, I have a feeling this patient probably had a foam dressing and the
Yeah, he
foam was
did.
giving back too much moisture. And
Exactly.
with too much moisture, you're getting this maceration around the area of the dressing. So
You can
this
see the
patient,
square.
yeah, and you may need a super absorbent here initially and an antimicrobial topically, like inidine topically, because you've got a lot of slough and two areas of different viscosity that might favor biofilm and pain, and then a super absorbent so that you take all that extra moisture away. And once this comes into bacterial balance, then you could think about a foam dressing, but foams are not all the same. In the very first foams, all the cells were the same and they give back a lot of moisture. Second generation foams have some smaller and some larger polyurethane cells. And what that does is you get more moisture retention and give back less. And so, and I would probably put the foam on, in a little bit different angle so that it's not quite hitting the same spots.
Yeah, I think that speaks to most of the things on this case. And silicone isn't always, as much as it is skin friendly, is not always the right choice. It can be a bit like a sponge if it's
Yeah.
not used in the right situation. So take home messages is talking to your patient, looking at what's going on. I think you can improve a lot of the things that you're doing for your patients. Next slide. All right, so we talked a little bit about neuropathic pain, and there's a lot of options available in terms of medication. And I think maybe you're prescribing or you're advising or educating patients about the use of these medications. Anticonvulsants have been used for neuropathic pain, and that's pregabalin and gabapentin. Their dosing is variable. I always recommend you start with a very low dose and increase very slowly because the side effects can be significant, especially in our elderly patients. Most important is dizziness and increased swelling actually in the extremity. But used with opioids, they can cause increased respiratory depression. So that has to be looked at. Tricyclic antidepressants have been around for a long time. Nortriptyline in low dose at bedtime, as well as amitriptyline. Some people like nortriptyline better as it has less anticholinergic effects, but it requires careful titration and watching the patient. The newer ones would be serotonin and norepinephrine reuptake inhibitors. Duloxetine is probably most commonly used, starting at 30 milligrams, but you can increase it up to 120. That certainly would be the top. I think 60 to 90 is used more commonly. Phenylvaccine, again, starting at 37.5 milligrams and titrating slowly up is effective as well. Cannabinoids are also used, and Dr. Sibbald will talk about that shortly. Opioids are not first line, very much second line drugs. There's a lot of concerns about the use of opioids, but I think one of the take homes from this is that these medications need to be followed, and you need to talk to the patients regularly and talk about the pain effect and increase them very slowly. And sometimes you have to use more than one medication to manage pain. Next slide.
Okay, so the cannabinoids, the CBD, is important in terms of neuropathic pain. THC is psychoactive, and you sometimes worry about using that. But let's go on to the next one. And it may help reduce, there is some evidence that it will, mix with THC, help reduce anxiety, chronic pain and inflammation, improve sleep, reduce seizures in childhood, chemotherapy-induced nausea, and improve symptoms of inflammatory bowel disease. So yes, they have a use. They are, I would say, third line therapy, and they're an adjunct in many patients. Next. Lower risk recommendations, and the nabilone is a synthetic one. And although it's beyond what we're going to talk about here, it is available. And if patients are going to use these, gummies and oils are better. Smoking is probably worse than smoking cigarettes. Let's go on to the next one. Andrew's telling me that we're coming up to our time limit, Robyn, but go
Yeah.
ahead, you speak to this.
Yeah, sure. As I pointed out earlier, I think we have to remember that more than one modality will be necessary to manage pain. And if you progress to the next slide, Andrew, we have to think of many different options. And more and more, we're thinking of non-pharmacological methods to manage pain, whether that be hyperbaric oxygen, TENS machines. Cognitive behavioral therapy has really advanced in terms of managing pain, as well as mindfulness, stress reduction. You can think of things like music therapy, and there's topical agents that do have evidence, and topical nitroglycerin. Also, keeping track of looking at wound intensity scores. And then there's things like the muscle pump activator gecko, which is the next slide we're going to talk about.
And what we have here is the baseline circulation with speckle imaging. And a gecko device is, I'll show you in a second, put around the where the perineal nerve is, just to the side of and below the knee. And it's got 10 activation points. And you can see the flux is increased 225% in the wound bed and 67% in the area around it. Next slide. And when the gecko was used for patients with venous ulcers, and they had 4 weeks of compression, and those that weren't healing at the expected rate were randomized to either continue compression or compression with the gecko. And the healing rates increased between weeks 4 and 8. And that increase in healing rate continued even at week 12 and week 16. So that it did give a prolonged, if you like, boost to healing. And it is something that we should consider in venous ulcers. Next. And why does the gecko work, Robyn?
Well, I think there's a lot of reasons. One of the secondary endpoints of that study, they did look at other things such as pain and quality of life indicators. And I think what we're looking at here is that you're getting an improvement in local blood supply. We saw it on that speckle study. So we're reducing the edema and inflammation. And I think is helping with the healing, but also the faster you heal, the more improvement in pain you get. So I think, we're modulating the sensory input by using this muscle pump activator, and it's impacting pain. So I think anybody who's interested, I think, I'm been using in the clinic, and I've just got a new supply of gecko to help some patients that have ischemic pain that's not amenable to angioplasty. But we're seeing how the gecko can help sort of improve local blood supply, reduce edema, and help the patient with a pain. Next slide.
Yeah, this is a patient of mine, a 70 to 80-year-old male, and had home nursing care. He did have bilateral femoral artery stent. We got these necrotic wounds, and this is part of the reperfusion injury, and it was recommended he have an amputation below the knee. And the pain was 15 out of 10. He came in a wheelchair. He was sleeping, sitting on a couch, and we did control the pain, both the neuropathic and nociceptive. And this was using acetaminophen. This was using Lyrica, and this was using nortriptyline. And we did occasionally have to use a narcotic agent. We did use the hypochlorous acid. We did paint with betadine, and it's the proximal area rather than the black areas. And I did some conservative and debridement. I couldn't touch them at the beginning. The initial debridement, I had to put some local anesthetic in. The long and the short of it is this man is now walking. His pain is a 1 to 2, if any. And you can see he's got tubie grip on there. And he has his life back. And I think that, and with both legs. And if you look at the toes on the a right foot. We did get a lot of that black tissue back, and we didn't get as much of a permanent defect, but there's a little bit less on the right side than the left side. But he's completely functional. Next. Okay, Robyn.
So the future of wound care, I think we need to look outside our traditional box and work harder to manage wounds and get them healed quicker. Understanding basic science, I think we're going to see a lot more diagnostics for fluorescence, maybe by fluorescence, looking at inflammation, infection, and bioburden, being able to develop smart dressings to understand what's happening at the wound base, and considering other options like the gecko or the muscle stimulator to improve blood flow, reduce edema, and possibly accelerate healing. So remember, blood flow is a currency of healing, and pain does improve as you heal the wound. So there's a real impetus to improve this pain or these wound heals to get them to heal much more quickly. Next slide. So I think it's important that we ask about the pain and quantitate the pain at each visit. What makes it better? What makes it worse? Local wound care, Dr. Sibbald went through the wound bed prep, knowing the cause and what's you're doing at the bedside that may be helping or hindering the patient. Consider the environment, the personal and health issues, contribute and modulate pain. And I think education and support is so important in terms of understanding the cause, listening to the patient, educating on medication, how they use, listen to side effects and other modalities, and then be open to other effective management strategies. Because I think we're all just, we get patients that have mixed venous arterial disease or arterial disease, pain that's out of control. And I think modalities and maybe less emphasis on pharmacology at times because of polypharmacy, I think is something we really need to work on. I thank you for this presentation, for allowing us to do this presentation. Hopefully, you can take something back to your bedside. These are the references that were used for the most part. And I think there's tons of questions I saw coming up, all of them very good. So I'll let Troy tease through those.
Perfect. Well, what I'll do is I know that some people might have to head out. So before they go, I just want to make sure that they could see the upcoming webinars there. So I'll keep that up as we chit chat a little bit more here. I categorize these a little bit. We'll start quickly with topicals and pain control. Can topical anesthetic creams like EMLA be applied directly to the wound bed, or should their use only be used in the intact peri-wound skin only?
There have been studies where EMLA, and I did do a couple of EMLA studies, and where they can be applied to open skin, and you don't really measure a systemic absorption of the modalities. You have to be careful about using large areas over at one time. And you probably prilocaine can cause some hemoglobin problems if you're not careful, but 30 grams or 60 grams, certainly safe. You do have to occlude it.
Okay.
We also
Fair.
use some lidocaine, like just 4% lidocaine topically on a gauze over some wounds. And it certainly is effective to use prior to debridement.
And you usually use Saran to occlude it.
Yeah, sometimes we do. Yeah. Yeah, it works really well.
And what about for chlorhexidine-based cleansing solutions? Should they be diluted before use, or
No,
can they be transferred directly into a spray bottle before using?
they can be transferred to a spray bottle. If they're safe to use in the mouth, they're safe to use in the groin or under the arms. And it already is only 0.12%. So you're dealing at a very small percentage. Don't dilute it.
Thank you. And what about for pain modulating foam dressings? Can they be put directly on the wound bed, or can they be used over an antimicrobial contact layer?
Robyn, do you want to take that?
For using the ibuprofen dressings,
Yeah.
Yeah.
it's important that the ibuprofen can get to the wound surface. So generally speaking, it should be in contact with the wound. I know some people do use another antimicrobial that you like, for instance, Bactogras that you can sometimes get perfusion through, but I think it's not ideal. So I think its manufacturer recommends that you just use the dressing to get its full ibuprofen effect.
Yeah, and if you want an antibacterial effect, compress with hypochlorous acid or PHMB. Leave it on. Do not wash it off with saline, and then you can put the ibuprofen dressing on, and you're going to get complete contact with the wound surface.
Moving into some compression topics a bit, is the ABPI required before starting light compression for edema?
That's a loaded question. Do you want me to do that?
Yeah, you start, and I'll add
Oh,
my
okay, you
2 minutes.
can think about it. So generally speaking, with arterial disease, it's important to do a proper history and understand what you think the patient's risk factors for arterial disease, keeping in mind the most common are diabetes, smoking, and age. If there's a big concern, that should send a red light to you. Then you do the exam, looking at clinical signs. If the pulses are palpable, I don't have a problem putting on light compression. If you can't feel a pulse, I would look at arterial insufficiency and put it together with the patient's history. So, Dr. Sibbald?
Yeah, I think first of all, you look at whether you've got dependent rubor when you raise it and it goes white. If they've got claudication and if the extremity is cool, you have to have great caution. Because edema wear works with the microcirculation and it's not compressing the whole area, it would probably be safe and that or a single layer of tubing grip is easy for the patient to take off if they had discomfort. But above that, I'd want to do an audible Doppler, which is not influenced by calcification. And I would want a biphasic or triphasic wave.
Thank you. And maybe just a clarification question. Someone was asking about whether gecko can be used in managing neuropathic pain for patients who do not have an open wound. And they asked about e-stim as well. If you can clarify again the difference, e-stim versus gecko, briefly.
E-stim is really a superficial type of mechanism that's stimulating the surface compartment around a wound. When we're doing with the gecko, we're doing you're stimulating the muscle. It's a myonerve stimulator so that you're actually getting right down to the muscle tissue. You're getting a twitch and you're increasing the circulation locally. So they are very different mechanisms. And I think the gecko would be much more likely to increase circulation in the lower extremity than e-stim. But Robyn, your take on that?
Yeah, no, I agree. I think e-stim, I don't think that they've looked at blood flow studies with e-stim. It's a little bit harder to manage because I think it's sometimes unclear what the the current that you're going to use and whether it's AC and DC and what the strength of that current is. So I think there is evidence and it's evolving evidence that we're helping with wound healing, but I don't think it has been shown to do anything for the arterial blood supply.
If I can just add that, sorry, I apologize for the fire alarm going off in the back. This building is notorious when it's cold. But even with e-stim, if you're getting a blood flow change, it's very transitory. It's during the session, and it's not like gecko where you're having something that's going to last throughout the day.
And keeping on the same topic, do we know whether gecko would be beneficial for patients with vasculopathy beyond its use in active wound management, or just anyways, patients with vasculopathy?
We don't know the answer to that yet, and
Okay.
I think it is something worth investigating. But there are so many factors in vasculopathy and so many different things depending on the blood supply, the amount of clotting, the chronicity of the problem that it will be very hard to study. And I don't even think in Jeff in the 120 or so case series. I'm not so sure that we have vasculopathy. Kathy, yeah,
I,
Burrows,
I,
if you're
I,
on the
I'm not
line,
a,
I'd be
I'm
curious.
not aware of any, Dr. Sibbald.
Yeah, Kathy, are you there? Oh, okay.
It is an interesting concept to use, though. I think it's
Yeah, yeah, yeah,
because
Maybe
there is a blood flow issue.
yeah. It's hard to study though.
Well,
maybe
Hmm.
bringing it back to compression for a second, Kathy, maybe just putting some words together there behind the scenes. A couple of questions we got here. One was about oh, sorry, I just lost it here. There we go. Um, how do you decide between single versus double layer tubular compression, especially when pain is a big concern?
Start low,
Uh,
go slow.
yeah, yeah.
And we had a couple of more specific questions about pain from our geriatric population here too. So what are your typical, or maybe a couple suggestions you might give to someone who is trying to go through some pain management approaches with older adults with chronic or recurrent wounds? And separately, we had a question about, actually, I'll wait till that one. We'll go with that one first. So in our older populations, what are some key tips for pain management?
I
Uh,
think
it,
yeah, go ahead, Robyn.
no, I think you need to know if it's neuropathic or nociceptic. And I think you need to keep with the principles of using a very low dose to start. I think the anticonvulsants are used frequently, but if you're going to use these, you really need to understand the side effects in terms of patients with congestive heart failure. So I think start low and go slow is the right answer to this one as well. And considering things like duloxetine and phenylvaccine are also options for the elderly. But if you look
Yeah,
at
and
the
I
Beers criterion, which is every medication that the elderly take, you can actually look those up on the Beers criterion. Probably all of them have, you know, uh, warnings. So,
Yeah, and I think the other problem is that the gabapentinoids are short acting, so you probably have to use like 25 milligrams twice a day, and one maybe in the morning and one maybe at bedtime to try and minimize those side effects. And 50 milligrams is only 1/12 of a maximum dose of 600 milligrams. So this go start slow and even if somebody gets disoriented with that much, you might even start with a part of a dose, and it's really a hard thing in the elderly, and you want to avoid nonsteroidal anti-inflammatories for nociceptive pain. And acetaminophen, 500 to 1 gram. And it's not often known in Ontario that the 500 milligrams of acetaminophen is on the Ontario drug benefit.
mhm. I think
And
if I'm doing these gabinoids, pentanoids, I always just start a nighttime dose and see how they do on the nighttime dose and then add a morning dose. Because I
Yeah,
think the sedative effects, just
yeah,
to make sure they're fine in the morning.
yeah. That's even being more cautious, and I think
Yeah,
there's a
I
certain patient population where that would be wise.
yeah.
I know we're getting towards a little bit further past. We'll try to maybe do one more question, but I did want to share this great comment from someone. I know that Unabut was brought up previously by I think it was by both of you two at a previous session. But this person said, following guidance from a previous webinar on Unabut applications, one of these clinicians treated a patient with bilateral venous leg ulcers and severe lymphedema, who could not tolerate lighter compression. So using that as well, or sorry, using fan-folded viscopaste under the, I think it was 2B grip, they said, both wound healing and edema improved significantly over several weeks and had a reduction in treatment frequency. So you know that the webinars are working. So I just want to say thank you and wanted to share that piece of information there. Let's maybe go to two questions a little bit more specific. One person was asking for malignant fungating wounds. What's the role of providone iodine in or iodine in managing pain or odor or bile burden while trying to keep some comfort for the patient?
I think
Or any
it's got
suggestions
a
for
big
approaching that?
role if bacterial burden is more important than tissue toxicity. And, they may be on pain medication to begin with so that you may be able to tolerate that. Otherwise, I'd probably use hypochlorous acid, leave it on, and then for any bleeding or friable tissue, use a calcium alginate.
And
Right.
what about with patients who have,
Robyn, what about your
oh, sorry.
comment
Yep,
on
go
that?
ahead.
Yeah.
Fungi wounds, I think you want to keep them dry in general. The exudate is usually what causes the odor. And I think you need a liquid to get into the nooks and crannies because they're often, if it's fungating, it needs to reach. So any topical antiseptic I think would be ideal, and you might need to use some sort of charcoal if odor became a significant issue.
And then specifically for patients with PG or pyoderma gangrenosum, what about approaches to that for managing neuropathic pain associated with that wound?
Treat the cause. And if you've got a raised border, it means the inflammation is active, and you really want to get rid of that active inflammation. And then you do want to address the pain. It's often very severe pain. And if it's attached to inflammatory bowel disease or rheumatoid arthritis or myeloproliferative disorder, you really have to treat the primary order that about 50% of them are associated with. Robyn.
Yeah, no, I agree. You got to treat the cause in that one, and once you treat the cause, it helps a lot. I mean, in the clinic, I mean, sometimes injecting with steroids settles it down if you get it acute enough, and you can help the patient. But I think you got to treat the inflammatory cause.
Yeah, and the interlesional steroids often need to be a little bit higher than we might use for other indications, like 20 milligrams per mil. And if you dilute it with equal parts xylocaine, it then gives them a local anesthetic effect as well.
Well, thank you both for touching on these. I know we had lots of great questions, and there's still quite a few that we won't maybe have the chance to answer today. But as I've been doing, my screen is sharing here, and there's going to be quite a number of webinars coming up between now and the summer. Some with Dr. Michael Stacy. Some of you may have been on a webinar with him previously, and then a mix of both Dr. Sibbald and Dr. Evans in the future too. So we encourage you to register for those and join us on some of these other topics. But for now, I'll just say thank you both to both Dr. Evans, Dr. Sibbald. It was fantastic having you on again. Your expertise is always so valuable. And looking at the chat and looking at the questions, it's clear that everybody took a lot from this. So thank you both for staying on a little bit longer and going through the questions. And we look forward to seeing you on. It'll be pretty soon in March. It looks like March 2nd will be the next time we have you on.
All right. Thanks
Thanks a
very much.
lot. Have a
Yeah,
good
appreciate
day.
it. Yep. Good night.